Hello, everybody. Thank you for attending the conference today. I am going to talk about exercise and the heart. As far as disclosures, I do not have any financial disclosures related to this talk. I wish that I either got paid to exercise or was financially invested in Orange Theory Fitness, but sadly, that is not the case. The objectives of this talk are to identify the unique risks of sedentary behavior, to explain how exercise positively affects multiple areas of physiology to improve patient outcomes, to detail some specifics about various forms of exercise, reveal a fat-burning exercise hack, so stick around for that. And I will discuss risks of too much of a good thing. In a prior talk I gave at this conference, I discussed the obesity epidemic and that 25 years ago, there wasn't a single state in our country with an obesity rate over 20%, and now there isn't a single state with a rate less than 20%. This map depicts a self-reported physical inactivity among US adults between 2015 and 2018. They were classified as, quote, inactive if they answered no to the question, during the past month, other than your regular job, did you participate in any physical activities or exercises such as running, calisthenics, golf, gardening, or walking for exercise? As you can see, the states that include Oklahoma that are the most inactive correspond to the states with the highest obesity rate. So is it an obesity epidemic or an inactivity epidemic? I hope those of you who attended my talk last year believe that food is definitely a problem and has led to the global epidemic of obesity. However, inactivity is also a problem. Data from 2010 revealed that in the prior 20 years, there had been a sharp decrease in physical exercise and an increase in average BMI. It was theorized that lack of leisure time physical activity, especially among young women, was responsible for the upward trend in obesity rates. This table here depicts the percentage of people who report no leisure time activity from the NHANES data, comparing the years from 1988 to 94 to 2009 and 2010. The highlight marks all women and all men, clearly demonstrating that both genders relate a significant decrease in leisure time physical activity. So if we're not exercising when we're not at work, what about when we're at work? In the early 1960s, almost half of the private sector US jobs required at least moderate intensity physical activity, whereas now less than 20% demand this. The estimated mean daily energy expenditure due to work-related physical activity has dropped by more than 100 calories per day in both men and women. So we're not active when we're at work, we're not active when we're at home, and it's a problem. And as if it weren't bad enough, along comes a pandemic. This is interesting data collected last spring, kind of in the heart of the shutdown. This is patients reporting the level of activity and sedentary time in their children, with younger children ages 5 to 8 being the dark bars and the hash bars being older children 9 to 13. This graph depicts how parents report that their children are much more sedentary, and the one on the right, they're much less active. Interesting is that 15% reported that their younger children are actually more active. I guess the younger children, when they're not at school, they're allowed to be much more active at home, and you can't keep a 6-year-old down, I have learned personally. The shutdown also caused a significant drop in step count in adults. This data is taken from fitness trackers, smartphones, and other pedometers obtained between January and June of 2020, using March 11th as the date of pandemic declaration. They collected data from over 19 million steps from over 455,000 people in 187 different countries. These are major US cities here on the left and large international cities on the right, with March 11th being about right here. And you can see the sudden decrease in step count globally. up to a 48.7% decrease with a mean 27.3% decrease in steps over the first 30 days following March 11th. Here is an audience response question. If you can get out your, I think you'll just answer it on the Zoom call. What defines a sedentary lifestyle? A, not standing or walking for at least 5 minutes every 2 hours while awake. B, spending more than 6 hours per day, 5 days per week in a seated or reclined position. C, not participating in at least 30 minutes of moderate intensity physical activity at least 3 days per week for at least 3 months, or not achieving at least 10,000 steps per day. The answer is C. You have to be at least moderate intense activity for 30 minutes for at least 3 days a week for the past 3 months to be living a non-sedentary lifestyle. So what is being sedentary? We classify activity in this level of physical activity in metabolic equivalents, with 1 MET being the amount of energy expenditure when you're just sitting quietly. You are sedentary if you're doing anything less than 1.5 METs. A sedentary lifestyle, again, is that definition that I just gave. A sedentary lifestyle is an independent risk factor separate from a lack of exercise for chronic disease. Being sedentary leads to, in adults, twice the risk of developing diabetes and cardiovascular disease, 13% increased risk of cancer, and a 17% increased mortality risk. In children and adolescents, a sedentary lifestyle has a strong correlation with obesity and a moderate correlation with worse blood pressure and lipids, poor self-esteem, and decreased academic achievement. Sitting time increases all-cause mortality. That is depicted in this graphical representation here, which demonstrates that there's an over 15% increased rate of all-cause mortality in people who sit almost all the time. This was also confirmed last year in a large meta-analysis that found that sitting time and TV viewing significantly increased cardiovascular disease, cardiovascular cancer and mortality risk. These associations were actually dose dependent. More important, sedentary behavior in combination with chronic disease or high BMI increased all-cause mortality risk, whereas physical activity was likely to alleviate the adverse associations. So unfortunately, my friends, sitting is the new smoking, and I try to tell all my patients this. But the work begins with you in the office. And as I hope I drove home last year, we need, as healthcare providers, we need to lead by example. This is interesting data of office workers, which divided people into the prolonger and the breaker. Both had the exact same amount of time sitting and then same number of step counts throughout their day, but the breaker took much more frequent breaks more often, although shorter throughout the day. And independent of total sedentary time and activity time, having a higher number of breaks in sedentary time was beneficially associated with waist circumference, body mass index, triglycerides, and 2-hour postprandial glucose. This is a tabular depiction of waist circumference demonstrating a significantly smaller waist size in people who got up and moved around a lot more throughout the day. I took this image off Google. This is just a representation of multiple different exercises that can be done right at your desk if you have a desk job where you're required to be seated the majority of the day. This is a schedule that I actually have through the Institute of Functional Medicine that I give my own staff that allows them to do various exercises in a little workout regimen throughout their day that provides them more time being active and less time being seated, yet still able to be at their desk and do their job. Being less sedentary leads to 43% higher likelihood of experiencing successful physical, psychological, and social aging. It has also been shown to be a better modulator of pain than being sedentary. Actual exercise has been shown in multiple trials to have numerous benefits. It decreases the risk of many disease processes. There's a 14% decreased risk for breast cancer, 21% decreased risk in colon cancer, 28% decreased risk of diabetes, and 25 to 26% decreased risk of ischemic heart disease and stroke. There are multiple benefits as far as our emotional well-being as well. It's been shown to increase BDNF, which is the miracle growth for the brain, and has demonstrated emotional and spiritual benefits as well. Other systemic effects of exercise include decreasing inflammation, increasing energy, and thus decreasing fatigue. It increases mitochondrial biogenesis and ATP production, which we all know is the energy currency of every cell in our body. There are multiple cardiometabolic effects of exercise. I'm not going to read through this list, but suffice it to say, numerous trials have shown multiple different cardiometabolic variables that improve with routine exercise. This was a study looking at healthy seniors without chronic disease and looking at various levels of activity throughout a lifetime, which demonstrated that at least 30 minutes of dynamic exercise 4 to 5 days per week performed over a lifetime can sufficiently prevent the decreases in LV compliance and distensibility that's observed with sedentary aging. This is the diastolic dysfunction that we see generally with aging. The rightward shift and flatter curves of the green and purple bars representing competitive athletes and committed exercisers show the decrease in diastolic dysfunction in this group. However, low doses of casual exercise, as represented in the red dots here, do not seem to prevent diastolic dysfunction of aging. Because of all the proven benefits of exercise, the U.S. Department of Health and Human Services recommends at least 150 minutes obtained over 3 to 5 days of exercise of moderate intensity cardiovascular physical activity, or 75 minutes of vigorous activity, again, over 3 to 5 workouts per week. They also recommend adding resistance training into the regimen. So what is cardio? It is defined as any sport or activity that works large groups of muscles that is continually maintained and performed rhythmically. So there's no specified heart rate zone for cardiovascular exercise. And I'll talk a little bit more about that later. We're going to have another audience response question here. This is about high intensity interval training. So when compared to moderate intensity continuous training, HIIT has been demonstrated to have more benefit with A, decreasing insulin resistance, B, weight loss, C, improving VO2 max, D, resting heart rate reduction, or E, A and C, or B and D. The answer is A and C. HIIT decreases insulin resistance and improves VO2 max. It is not great for weight loss, and it does not significantly reduce resting heart rate. And I'll talk about that a little bit more here. HIIT, also called high intensity intermittent exercise or sprint interval training, is interval training cardiovascular exercise strategy alternating short periods of intense anaerobic exercise with less intense recovery periods until one is too exhausted to continue. Sounds fun, right? Again, multiple trials have demonstrated those benefits I already discussed. It also improves cognitive control and working memory capacity when compared to a blend of board games, computer games, and trivia quizzes. So it's also good for your brain. There are multiple different regimens, Peter Coe being the first to define high intensity interval training as he coached his high schooler in track sprint intervals. Multiple people are familiar with the Tabata routine. The important thing about HIIT is that the actual high intensity interval should be done at near maximum intensity. And more important, the recovery should be at least 50% of the high intensity interval duration. I see a lot of boot camps and various workouts that do like 45 seconds on and only 10 seconds off. This is not how HIIT has been designed to be beneficial. That is not how the trials have been done. That is actually pro-inflammatory and promotes injury. So I do not recommend those intervals. What about aerobic or cardiovascular versus resistance training? Endothelial dysfunction is a characteristic of hypertension and an early marker of atherosclerosis, and flow-mediated dilatation is an independent risk factor for future cardiovascular events. This trial exercised adults with hypertension and pre-hypertension for 40 minutes twice a week for 8 weeks. They did both aerobic training and resistance training, and they measured endothelial dependent vasodilatation and blood pressure. Both aerobic and resistance training produced a similar improvement in blood pressure reduction and vasodilatation, and the combined training actually showed the greatest increase in flow-mediated dilation. What about walking? A 2020 systematic review demonstrated that adding 1,000 steps per day helps to lower risk of all-cause mortality and cardiovascular morbidity and mortality in adults. For each 1,000 daily steps added above baseline, the risk reductions were as high as 36% for all-cause mortality and 21% for cardiovascular disease. While the number of daily steps needed for optimal health is not clear, studies indicate health benefits are present below the recommended 10,000 steps per day that is advertised by the American Heart Association. What about running? There have been numerous trials of running. A large pooled study demonstrated that running compared to no running demonstrated 20% lower risk of all-cause mortality, 30% lower risk of cardiovascular mortality, and a 23% lower risk of death from cancer. Any amount of running, even just once a week, is better than no running at all. But running is not a dose-response association, and higher doses of running may not be necessarily associated with a greater mortality benefit. What about dancing? There have been, again, several trials looking at dancing, some done in cardiac rehab patients. It has been shown to increase VO2 max, lower body muscle power, and static balance in walking. Static balance is it's as good as walking in older women after 8 weeks of intervention. It's also as effective as walking in improving cardiovascular and fall risk in healthy older women. Basically, engaging in any type of intervention, dancing, walking, stretching, induces metabolic improvements. There have been several trials in Pilates as well. It has been demonstrated to improve blood pressure in hypertensive and pre-hypertensive adults. Even a single episode of Pilates has been shown to have almost a 5 to 10% millimeter reduction in the blood pressure an hour after the workout. And long-term mat Pilates also has benefits in blood pressure, arterial stiffness, and circulating nitric oxide. Tai Chi also has proven cardiovascular benefits. It lowers blood pressure and increases quality of life in hypertensive adults. There is a cholesterol benefit in that it decreases total cholesterol, triglycerides, LDL, and also lowers blood glucose. There hasn't been a proven benefit of Tai Chi in the HDL, however. Yoga. Also, there are many trials on numerous factors from a mental health standpoint, as well as cognitive and cardiovascular. It has been demonstrated to improve LDL and HDL when compared to people who do not do yoga. It improves BMI and systolic blood pressure. It also, the benefit is additive when breath work or meditation is practiced in addition to yoga 3 times per week. So what is the best form of exercise? The one that you love, so that you will actually do it and do it regularly and enjoy it. Here is my final audience response question. What is the best way to promote fat loss with exercise? A, carb load before each workout. B, do resistance training for 20 minutes, 6 days per week. C, do HIIT with your heart rate 80 to 90% of your max for 20 minutes, 5 days per week. Or D, do moderate intensity continuous training with your heart rate 60 to 75% of your max for 30 minutes, 5 days per week. Or forget about the exercise, commit to eating low fat and at least 3 hours on the couch per day. This is your exercise hack here. I'll explain it in more detail on the coming slides. The best way to burn fat is to do moderate intensity continuous training with your heart rate 60 to 75% of your max. What about these heart rate zones? There's a lot of hype about this, and many proprietary workouts out there like Zone 4 and Orange Theory Fitness, of which I am a complete addict. Our resting heart rate is just that, our average heart rate at rest. We can get that from heart rate monitors that we wear while we're asleep, or we can just take an average over a week of our first morning heart rate before we get out of bed. Our maximum heart rate can be determined in a couple different ways. The most common way is to take 220 minus your age. Some formulas use 226 minus the age for women. Or you can actually achieve your maximum heart rate through graded exercise like we do during an exercise treadmill test. Or if you perform this kind of exercise in your routine workouts, like I do, you can just determine it by achieving it in a workout. Heart rate reserve is a way of calculating different heart rate zones, is the Carvonen method. This can be a little bit more accurate to actually target these various zones to achieve your goal in conditioned athletes. Don't use Carvonen for people who are on beta blockers and can't get their heart rates up. I saw that documented a couple of times online. I would not recommend that. It will greatly overestimate where they need to be. This is my favorite study that I'll talk about in today's talk. It was an elegant study done on athletes where they did graded exercise and looked at their aerobic capacity as well as fat oxidation to determine where were they burning the most calories and where were they burning the most fat. And what they determined is that the aerobic zone and the fat burning zone have a lot of overlap, 68 to 87% max heart rate for aerobic and 59 to 76 for fat burning. But the very interesting thing is that they found that the highest calorie burn comes here at the upper end of the quote fat burning zone, or the green zone if you're doing zoned physical activity like in Orange Theory. We burn over twice as many calories here as we do over here when we're in the orange and the red zone. So if the objective is metabolism of fat calories during your workout, you need to work out in the green zone, not in the orange and the red zone, which is kind of contrary to popular belief. I wish I could spend a lot more time on this slide because it truly is where I geek out when it comes to exercise and personalizing it for my patients. I'm not going to go through all of these zones here, but basically I've used the different methods to calculate my fat burning zone, which again is the green zone. This is my personal data from my Orange Theory workouts on January 11th and the 27th. These heart rates and zones here are obtained from my heart rate monitor. That is my Orange Theory monitor. And this is actually my histogram that I get from my Fitbit. I'm such an exercise dork that I wear 2 separate heart rate monitors while working out. But what I want to point out here is that on January 11th, I got 20 splat points, which means I spent 20 minutes in the orange and the red. And here on the 27th, I only spent 15 minutes in the orange and red. But lo and behold, I burnt more calories here when I spent less time in the higher end of the zone and more time in the blue and the green zone, further driving home that this is where we burn fat and this is where our maximum calorie burn comes. In Orange Theory, they have gathered data from multiple trials and determined that it's the sweet spot is to get 12 minutes in the orange and red, and that allows you the 36-hour afterburn, or sorry, the EPOC, which is the excessive post-exercise oxygen consumption. So you continue to burn more calories than if you hadn't worked out if you just get 12 minutes in the red and the orange, and then you'll burn more calories during the workout and burn more fat if you keep the rest of the time in the green and the blue. Also, to further add to your hack that you can use in your own workouts and for your patients, it requires more calorie burn to go from one zone into the next. So to like get that sudden increase in your heart rate to get you into the zone. So I also burned more calories in this workout because I went into the orange and out and into the orange and out multiple times throughout the workout. And that results in a higher calorie burn versus over here, I jumped on the treadmill and it was a very hard workout. And I went into the orange and I could hardly ever get out of the orange. I dropped down here a couple of times, but for the majority of the time, I got, at least 3/4 of my splat points all at once. And so that results in a lower calorie burn. I would be remiss to do a talk about the heart and exercise and not talk about cardiac rehab. I won't read this definition to you in the essence of time, but cardiac rehab is a comprehensive model of care with established core components that include structured exercise, patient education, psychosocial counseling, risk factor reduction, and behavior modification. There's a lot of proven benefits. There's a 47% lower risk of death and a 31% heart attack risk in people who complete even just one session of cardiac rehab. The general program is about 36 sessions, if I recall. It saves the system money as well. Unfortunately, only 10% of eligible patients are ever referred, and less than 3% actually complete even one cardiac rehab session. So it's highly underutilized. I've listed here the criteria for eligibility for cardiac rehab. These have kind of evolved over time, but basically if you've had a heart attack in the past year, if you've ever received stenting or PCI and have stable angina, if you've had any cardiac surgery, and if you have chronic stable heart failure, you're a candidate for cardiac rehab. When is too much of a good thing? Studies assessing adverse long-term effects of exercise are vastly done on elite endurance athletes, like the repeat marathoner, Ironman participants, distance cyclists, etc. So I would caution you to be very careful extrapolating Lance Armstrong data to your patients. In the vast majority of people, you cannot over-exercise if it's done properly. There have been a couple trials looking at endurance athletes. This is interesting data from a trial that looked at marathoners, half Ironman, full Ironman, and alpine cyclists, and measured various markers. This is a graphic representation of troponin levels a week before the race, immediately after the race here, significantly elevated, still a little above baseline the next day, but it all returned to normal within a week. It's also this form of high elite endurance athletics has been demonstrated to have transient reductions in right ventricular ejection fraction and increase in volume of the right ventricle. Over months to years of this repetitive injury, this process in some individuals can lead to patchy myocardial fibrosis, which could potentially create a substrate for atrial and ventricular arrhythmias. These are delayed gadolinium enhanced MRI images from 5 highly trained aerobic athletes from a normal study. Here you can see the left ventricle and the right ventricle. Completely black is normal. The white in the interventricular septum represents a scar in the images from these 5 athletes. The proposed mechanism is basically sustained elevations in heart rate, blood pressure, cardiac output, and chamber volumes, generates a large quantity of free radicals because it stresses the heart. This then increases oxidative stress, causing myocyte dysfunction, which then stimulates immune cells to secrete cytokines, ultimately resulting in collagen production, which lays down fibrotic tissue. What about exercise and atrial fibrillation? There have been a handful of trials, again, really in elite athletes, repeat marathoners, competitive cyclists, which demonstrate over time this sort of athleticism and exercise can increase one's risk of atrial fibrillation and atrial flutter. It is typically paroxysmal, and most episodes have been vagally mediated. Other proposed mechanisms include atrial ectopic beats, inflammation, atrial enlargement with dilatation and fibrosis, and increased vagal tone. These are the references noted in that table that I made if anybody wanted to go and review them. So in summary, sitting is the new smoking. I hope you all can believe that. A sedentary lifestyle is an independent risk factor separate from the lack of exercise for cardiovascular disease, diabetes, death from cancer, and all-cause mortality. Routine exercise has numerous beneficial cardiac effects, as well as other systemic benefits, and has a positive impact on mental, spiritual, and emotional health. The best form of exercise is the one that you love, so that you will actually do it, as almost all forms of physical activity have been shown to have benefit. Don't forget the 60 to 75% max heart rate hack for fat loss. And undesirable effects of exercise occur mostly in extreme endurance athletes and do not really pertain to the majority of our patients. And please don't forget about cardiac rehab in patients that are candidates. Thank you to everybody for joining us virtually. I wish we could all be together, but maybe next year. And if I have any time, I will entertain questions.